Hi everyone, thank you for still being with us. I hope you enjoyed the content that we prepared for you today. Now we'll move on to the question and answer session where we have our four esteemed panelists here, Dr. Khairul, Dr. Azrin, Dr. Amir, and Dr. Nabilah. So we'll move on to the first question. This is from Amiruddin Ibrahim. Any additive to LA to prolong duration in a single block? This question I'll direct to Dr. Khairul.
Thank you, Dr. Amiruddin, for the questions. So, Desai et al. Wrote a review article in Current Opinion early this year comparing different adjuncts to prolong the local anesthetics. So, the example adjunct that we can use are the dexamethasone, clonidine, Presidex, and magnesium. But we have to be very cautious whether this adjunct has preservative or not, because preservatives is neurotoxic. So the most interesting adjunct would be the dexamethasone, which can prolong up to 400 minutes. One RCT, they compared between perineural dexamethasone and IV dexamethasone. For perineural dexamethasone, they gave like 4 milligram, and IV dexamethasone, they gave 0.1 to 0.2 milligram per kilo. They found out that it was comparable. So in my practice, after I perform regional anesthesia or blocks, I will give IV dexamethasone to my patient to prolong the effect of my LA.
Thank you, Dr. Khairul. Next question, we have Faiz Nordin, who will ask that for rectus sheath block, should we practice a 2-quadrant technique or a 4-quadrant technique? This question I'll direct to Dr. Nabilah.
So basically from my lecture just now, whether we should use a 2-quadrant or 4-quadrant really depend on the maximum dose and also the maximum volume that we can give to a certain patient. If you want to look at the effectiveness in giving the 2-quadrant or 4-quadrant, because there's no data to support it, so we can use either one. But there's nothing wrong in doing the 4-quadrant as well, as long as we are very careful with all the structures, especially the peritoneal structure below the umbilicus.
Thank you, Dr. Nabilah. So the next question is from Noor Fadlina. Is there any difference in the reduction of a pain score outcome between pre and post-op abdominal block? For this question, I'll ask Dr. Amir.
Okay, I reckon these questions based on my preference to block the patient, the rectus sheath block post-op. My main objective to block the patient post-op not because of there is reduction or difference in pain score. My aim is actually if I block pre-op, because it's a single shot, the duration of post-op analgesia will be reduced because in the ward. So that's why I opt for post-op block to get the longer duration of post-op analgesia. If the question really thinks if there's a pain score difference, I don't think so, but I don't have any evidence.
Thank you, Dr. Amir. Maybe Dr. Amir, you would like to answer the next question from Noor Fadlina. So the question goes, if we plan for rectus sheath catheter for post-op pain management, where is the ideal position of the tip of the catheter? And what kind of catheter should we use? Is there any regime for the local anesthetic?
Okay, this is a tough one. I think the first, I've never inserted a catheter in the anterior abdominal wall. Okay, I think the anterior abdominal wall is a complex abdominal wall where, to me, it's a bit difficult to open up the space. But there's the rectus sheath block, the layers in between the rectus abdominis and the rectus sheath is a potential space to, if we want to insert catheter. If you ask me about the ideal position, you have to tailor the catheter according to the surgical incision. And because the surgical incision is a long incision, usually it's a long incision, I would recommend you use a multi-orifice catheter, which we don't have in Hospital Kuala Lumpur. And I think whether using an epidural catheter can replace a multi-orifice, I'm not so sure because I've not tried that. Okay, but theoretically, multi-orifice catheter is better to cater for a long surgical incision. And I think there's a catheter in the market which is by Payung, the Infiltra Long. I've never tested the catheter, I've never used before. And the drug regime, I would say a diluted regime will suffice. Example like 0.2% ropivacaine or 0.1% chirocaine or bupivacaine will do.
Thank you, Dr. Amir. Next question is from Katina, who is asking us to share our experience in HKL in managing patients with bilateral ESP catheters. Could we share some, in terms of drug infusion regime? Maybe Dr. Khairul would like to answer this question.
Thank you, Dr. Kartina, for the questions. HKL currently coming out with the guidelines for PCRA, patient control regional anesthesia. So in terms of experience, we have inserted bilateral ESP for bilateral rib fractures. So we are using PCRA to manage this kind of patients. Bilateral catheters were inserted. So the dosage would be for the ropivacaine. The drugs must be not exceed 770 milligram per day, and for liver bupivacaine not exceed 400 milligram per day. So we are using PCRA. The infusion basal rate is about 5 mils per hour with the lockout time 15 minutes, and the bolus drugs given is about 5 to 10 mils of bolus dose. This is a plain block, so we need volume rather than concentration. So we must dilute our LAs. For example, ROPI 0.1, and if the patient is very thin, so we maybe need to dilute to 0.05%.
Thank you, Dr. Khairul. We have another question from Amiruddin Ibrahim. Any comment on placing a catheter in the transmuscular quadratus lumborum? So maybe perhaps Dr. Azrin would like to answer this question.
Okay. There are various approaches to QL blocks. I think one in question was the transmuscular technique. So I guess depending on what type of catheter that you use, we have the catheter over needle and also the catheter through needle catheters types. So if you are using the catheter over needle, catheter through needle, then means that you need to cover for the larger diameter of needle that you use. So you may need to cover that with tissue glue. So that's one. Or if you are using the catheter, if you're not using the catheter through needle, then I recommend you to try and perform the block using the catheter over needle technique. I think at the moment that we have one of the catheters from Payung, the ECAT. The other way is that you can actually perform the anterior subcostal approach of the QL block, whereby I did not demonstrated that, where you need to perform the block along the longitudinal axis of the quadratus lumborum muscle, and by using that technique, you may be able to insert a longer length of catheter into the plane, and hence it may be more stable and less easily can dislodge. So I guess those are the few options that you can actually try and see.
Okay, we have a question from Saiful Ashar, who is asking, what is the best block for the para-umbilical hernia repair and Tenckhoff insertion procedure together? So maybe Dr. Azrin would like to answer that question.
Okay, it goes back to the anatomical knowledge of the incision and also the procedure. So I guess you can perform rectus sheath plus the tab block. You can also form, if you want the less attempts or less puncture, then you can perform the posterior approaches. You can either perform a single ESP or also a single QL block. So those are the other options that you can have. But as for what is the best block, actually it depends on what you're comfortable with, your experience level, and also the patient's body habitus. So I guess it's nice to have those options, but at the end of the day, what is best in your hands?
Thank you, Dr. Azrin. Yeah, we have one question from Faizal Hisham, who is asking that for open splenectomy with a rooftop incision, is it proper to do both unilateral subcostal and classical tab block? Maybe Dr. Azrin would like to answer this question.
Okay, so as I understand the question, if it is for rooftop incision, just for splenectomy, then I guess a more appropriate block will be something approaching from posterior. So since the incision is at the point of the subcostal margin, so I guess if you were to perform it post-surgery, you would have a disruption of tissues. Or again, if you perform it pre-op, then the surgeons may have some difficulty because of the disruption in the tissue planes. So for me, I would consider something more proximal. Either you can do a serratus plane, which I mentioned just now. Make sure it is below the nipple line and also below the fifth rib at the mid-axillary line. That is one option, which is the serratus plane. Or you can go further more proximal, which is the ESP or even paravertebral.
Okay. Thank you, Dr. Azrin. Next, we have a question from Hussein Ahmad, who is asking, am I right if I do bilateral intercostal block 10, 11, 12 is equal to bilateral tab in terms of coverage? Perhaps Dr. Nabilah would like to answer this question.
Well, Dr. Hussein, I think from the anatomically, it should cover if you are doing the bilateral intercostal block. But the difference is that if you are doing the intercostal block, we are doing like 6 injections instead of if you are just doing a bilateral tab, which is only a 2 injection. So I guess it will be easier to do the bilateral tab rather than the multiple injection of the intercostal block.
We have another question from Anor Hidayah. What volume for all 4 injections for midline laparotomy? Dr. Nabilah, would you want to answer this question?
Okay, for a midline laparotomy, since you are asking about the 4 injection, I'm assuming the incision would be very huge. So for my practice is that most of the time I'm using a total volume of 60 mils, meaning that at each injection I would deposit around 15 mils. About the dose, it really depends on the maximum dose that the patient can have. So, but most likely around 0.2% of ropivacaine or 0.1% of ropivacaine. It really depends on the patient's weight.
Okay. Next, we have a question from Dr. Shah, who is asking that what is the abdominal interfacial plane block to anesthetize the visceral innervations? Dr. Nabilah would like to answer this question.
Okay. So I think from my lecture, I've clearly made it out. The anterior approach, which is the TAP block and the rectus sheath block, will not be able to have any kind of a visceral innervation, but unlike the posterior approach, which is the QL, quadratus lumborum, also at ESP. So I think that answer your question, Dr. Shah.
Thank you, Dr. Nabilah. We have another question from Dr. Shah also. Is it now a standard practice in Hospital Kuala Lumpur to include abdominal wall blocks for all types of laparotomy? Dr. Nabilah, would you care to answer this question again?
Okay. It depends on the attending anesthetist and also patient. If patient consented and the attending anesthetist is okay with it, we try to implement and put the abdominal wall block as our multimodal analgesia for a patient with laparotomy. And most of the time, patients who are much elderly or big size patient that we want to reduce the opioid, they would be our aim for sure that we want to use the abdominal wall block to reduce the opioid consumption.
Okay, thank you, Dr. Nabilah. Next, we have a question for Dr. Azrin from Dr. Saiful Azhar, who is asking, will you do a bilateral lumbar ESP for laparotomy? And what is the total volume will at least be 30 to 40 mils?
Okay, I think I've demonstrated during the session today. It is not actually a lumbar ESP, so it depends on where is the incision. So I guess I've demonstrated the lines along which that you are to inject your local anesthetic for a abdominal dermatome. So I guess it is technically not lumbar per se, but it is actually lower thoracic and also maybe just the upper lumbar segment. So I hope that answers part of the question. The other question is the volumes depends on the body habitus as well. But at the moment, if you were to perform bilateral blocks, then minimum should be about 20 mils per side, which is up to 40 mils bilaterally. So depending on what's the weight of the patient, let's say for then it has to be calculated that it should not exceed the recommended toxic dose. So for ropivacaine is 3 milligrams per kilogram, and also for levopivacaine should be about 2.5 milligrams per kilogram. So as long as you are within this calculated estimated toxic level, toxic doses, then it should be okay.
Thank you, Dr. Azrin. We have a question here for lumbar ESP. Do you prefer to use the linear or curvilinear probe? Maybe Dr. Azrin would like to answer this question.
Okay, technically, it should not be that deep, like I've demonstrated just now. But also again depends on the body habitus. So I guess the images should be the same, even if you use the curvilinear probe. Just that it is because of the resolution, it is slightly different, and because of that, you have to be a bit more tedious and more focused on using it. But I guess both probes can be used, and you are actually looking at the muscles, so you are actually not looking at specific structures that is deeper. So I guess it is still okay to use a curve probe depending on the body habitus.
Dr. Azrin, sorry, there's just to add on to that question. Would you say that most of the obese patient that you would do a lumbar that you will perform a low thoracic ESP, would you automatically more prone to choose a curvilinear probe rather than a linear probe?
Not necessarily. So if I can actually see by using a linear, and on some ultrasound you can actually have a convex mode, so you can actually expand the deeper view so that you can actually see the structures. So I guess it is possible that you can actually use a curvilinear probe, but usually you can try and test the machine that you have and see the depth of the screen.
Can I add something on this? Uh, I guess it also depends on the system of ultrasound that you have in your institution. I think in high-end ultrasound unit, looking or scanning with a high-frequency linear probe, 5 centimeter and slightly deeper than that is not a problem. But in some unit, I think 5 centimeter in high-frequency linear probe is the max that you get a good good image. And in that case, I would straight away use a low frequency curve probe. I actually personally prefer a low frequency curve probe because I like because it covers a wider range and I can see more structures. I mean anatomical structures, which I prefer that way.
Thank you, Dr. Amir. We have one more question from Faizal Hisham, who is asking for open hepatectomy. Can unilateral ESP block be used as an alternative apart from epidural catheter infusion? Maybe Dr. Khairul, would you want to answer this question?
Thank you, Dr. Faizal. Previously, epidural is considered as a gold standard for the management of the post-operative pain and the peri-operative pain. However, since the introductions of ultrasound-guided regional anesthesia, this practice needs to be revised. So, for open hemihepatectomy, you plan to perform lower thoracic ESP, I suggest you to insert catheter for the post-operative or peri-operative pain management. ESP is very safe as compared to epidural or paravertebral block because it's far from the pleura and you have transverse process as a guard from your tip of needle entering the no-fly zones. So I suggest you to insert catheter for this kind of case.
Thank you, Dr. Khairul. Actually, we have one question from this Yotoku. Yeah, maybe I'll open to any panelists who want to answer this question. As for ESP block, we inject only one, which is at the T5 for both sides of the spine. So would any panelists who want to comment on this?
Okay, I probably just start. The T5 level is actually the lowermost margin between the borders if you were to do a chest wall block or an abdominal wall block. So if you are providing ESP block for a chest wall block, then this should be the lowermost level that you should see on the ultrasound. If you were to perform abdominal wall block, then this is the cranial most structure that you should see, and tailor to where is the incision. If the incision is midline, then you have to provide bilateral. But if it is over one side, then you need to only block unilateral. So I hope that answers the question. The T5 level is actually the gate between chest wall and abdominal wall, and this is illustrated by the rhomboids.
Okay. We have one last question. It's from Dr. Shah as well. Would it be more objective to count the thoracic vertebra from T1 thoracic level? T1 transverse process at the supraclavicular view. Maybe anyone or a panelist who would like to answer this, comment on this?
I think if the plan is to block at T5, I think counting from T1 transverse process is acceptable. But if you plan to block at T10 transverse process level, it will take some time to count. In the end, I don't think you have to be super accurate to deliver the local anesthetic. Even if you miss 1 or 2 level, should be okay, because the spread of local anesthetic will travel up and down in between the erectospinae muscle and the transverse process. So if you are missed by 1 or 2 level, I think it won't make a very large difference. So I prefer if you block at the lower thoracic, counting from T7 would be good enough. If you want to block at high thoracic, yes, counting from T1, it's an option.
Thank you, Dr. Amir. We have had lots of questions that came in. Unfortunately, we are running out of time, so we won't be able to answer all the questions, but we will get back to you. And we'll end the Q&A session here. I would like to thank the panelists and we have come to the end of our webinar for today. Again, I would like to thank Toyo Adtec, GE, for making this event a success. And also, I will thank the viewers at home. Thank you for taking the time to be with us and giving us the opportunity to share to you the interfascial plain blocks for abdominal surgery. We hope that today's session will be fruitful, and we will see you in another day. Thank you. Thank you. Thank you for joining.